So now we're up to our next speaker, Dr. Sam Fillingane. Sam Fillingane is an active physician trying to improve cardiovascular outcomes wherever he goes. Dr. Fillingane has worked in multiple roles that helped him identify and improve ways to reduce cardiovascular risk while teaching this information to physicians and patients all over the world. Dr. Fillingane is presently Chief Medical Officer for Cardiovision Care, the distributor leading the way in the introduction of multifunctional cardiogram, MCG, to the market. Dr. Fillingane is also an Associate Professor of Clinical Medicine at William Carey University College of Osteopathic Medicine. Dr. Fillingane is board certified in family practice with over 32 years of experience before joining the staff of the WCU-COM. Dr. Fillingane's family practice office in Jackson, Mississippi focused on cardiovascular risk reduction, taking care of high-risk cardiovascular patients from all over the country. In addition to his busy medical practice, Dr. Fillingane was the Director of Medical Education and Medical Director for several large national cardiovascular labs. Dr. Fillingane taught numerous CME medical courses for physicians at local, regional, and national levels. It's been a goal of his 4 years to see cardiovascular risk decline nationally. As cardiovascular disease continues to be the leading cause of death and declining quality of life for so many good people all over the world. Dr. Fillingane's teachings efforts eventually have reached out to the general public and medical students in further hopes that cardiovascular events would decline. Dr. Fillingane hosted the nationally televised program Straight to the Heart. It aired on My Family TV Network, the Retro Network, and the Comcast National TV Network, with 52 episodes devoted to helping patients better understand CV risk. Dr. Fillingane has developed the 10 inflammatory disease state models that he touts as the basis for identifying and treating cardiovascular risk successfully. Doctor.
Well, it's a joy to be here today, and I thank you for the invitation. I'm excited to go anywhere and talk about cardiovascular disease. I had them put this headpiece on me because I also am a walker when I talk. But I want to engage with you. I want to see your eyes. I want to make sure that we're on the same page, and I can do that better when I move about. Now, the multifunctional cardiogram is probably the biggest cardiovascular development in the history of my career. This is the biggest breakthrough that we've ever had, in my opinion, because it helps us see 26 things about the heart we've never seen before. I'm going to let you read the objectives and then we'll move on because so much to talk about. This device, literally, if you're practicing medicine that deals with anyone to do with heart disease, this is going to change your practice. Now, what is a multifunctional cardiogram? The multifunctional cardiogram is a device that is an EKG using artificial intelligence. It uses 2 leads instead of 12 leads. It changed from time domain to frequency domain and is able to see a tremendous amount of information. They took 200 data points, 168 electrical points, and they used some very fancy math. And then this artificial intelligence went to work. When I made these slides a few weeks ago, the 3 million people were tested at that time. We've now crossed 4 million. The longer you use artificial intelligence, the smarter it gets. When this thing started, the sensitivities and specificities were in like the 84, 85%. It's already now in the 92 and 91% range. And so sensitivities and specificities are going up, and it's not just looking at ischemia, it's looking at so much more. This device is big. I think it's so big that it's actually larger than Google. If you can imagine how big the software program is that put together Google and realize it almost doubles the size to put together this information in a way that you and I can make sense of it. This device looks at those 26 things that we've never seen before, and I'm going to show those to you in just a short minute. Now, what makes this device so special? One of the key things that makes it special is you can see this disease early. So many of our ways of taking care of cardiovascular disease is picking up on a person when they're caught late. And once you're caught late, it's so much more difficult taking care of disease. My claim to fame historically in medicine was 30 years ago. I was able to understand cardiovascular disease well enough to take high-level plaque-related patients and reverse the disease. Plaque that was 95% occlusive could become 50% occlusive, could become 30% occlusive, and eventually become 0% occlusive. Because plaque can go away if you address the right things. And for so many years, we just weren't addressing the right things. However, had we been able to come up with a simple device that didn't use contrast, that didn't use radiation, that didn't use anything that was hard on the patient's body, and see disease early, wouldn't that be wonderful? Well, doggone it, we got it now. You can actually put this device on a pregnant patient. You can put it on a newborn baby. You can put it on someone of any age and feel safe about it because there's absolutely nothing dangerous about electrocardiographic issues, and you can see the disease very early. I guess I'm going to look down here better. You can pick up unstable plaque. I think sometimes patients and even some doctors get this confused. The reason the first symptom of a heart attack is the heart attack itself is because 2/3 of heart attacks occur in patients with unstable plaque. When that plaque becomes unstable and ruptures, it creates a clot, which takes you from 40 to 50% occlusive to 100% occlusive instantly, and you have symptoms. If the first symptom of a heart attack is the heart attack, it makes sense to catch the disease earlier, and it also makes sense to see when it's unstable. Wouldn't you like to know if that patient has unstable plaque and is scheduled to have a heart attack in 2 months? Simply because you picked it up on your device and were able to get a clue. This device uses a simple scoring system. It's one that doctors and patients alike can understand. The score goes from 0 to 22, 0 being no disease, 22 being the worst disease. I envision this going into every primary care office in America. Every physician that has an EKG now will have an MCG in 10 to 15 years. Once you've used this device, you will never go back to a regular EKG because simply you won't want to. There is so much more information. It's the difference between a Cadillac and a tricycle. And when I want to go to work, I would much prefer the Cadillac. If your disease score 1 year is 1.2 and you come back for your physical exam the next year and it's 2.2, you realize your disease is worsened. If it's 3.5 the next year, it's worsened, and anything over 4 is considered significant. A recent study looking at this data to see when heart attacks begin, 4.6 was the number. So anything over 4 could be considered dangerous. If you saw your number approaching 4, you sure better get on the stick, and this device can give you that information. Now, patients, when they see that, they will respond because generally patients are scared of heart disease. It typically runs in a family. They've known someone that died suddenly from it, and when you start saying, I've got problems with my heart, that perks up their attention. Small vessel disease. I see a lot of women in the audience today. We all take care of women, even if we're men practicing medicine, and 50%, 49% of women have small vessel disease before they get large vessel disease. It took me a long time to get my head around this, but apparently what happens is women will get small vessel disease, the little vessels that come off the large vessels that go directly into the muscle, and they will grow these disease vessels until they get a point of symptomatic disease state. They will end up seeing their heart doctor, they'll get a heart cath, they'll be cathed and told they're totally normal. Only within weeks to months later, once you're symptomatic, a switch flips. And once that switch flips, you go from small vessel disease to large vessel disease immediately, and you will totally occlude your artery within 6 months. Imagine having a heart cath 6 months ago and showing up with acute coronary syndrome less than 6 months later, and how surprising that is for both the patient and the doctor because they were just told they were normal. But this device sees that small vessel disease, and it sees it in its earlier states, so you can actually identify a person that's developing it. Now, 49% of women do this, 15% of men do this, so it's not exclusively a woman's problem. But once you have it, we need some device to pick it up. I used to do a special test called a cardiopulmonary exercise test. You could see small vessel disease with a cardiopulmonary exercise test. The problem was it took almost 2 years to get good at interpreting it. It was a complicated test. This test is very simple. In just a matter of minutes, I can show you how to understand and pick up on small vessel disease. Heart stiffening. 300,000 people a year in the United States die from heart failure. 5 million people suffer from it. It's a great problem in the hospitals. It creates a circular door for patients. Wouldn't it be nice to know 6 to 8 years before your patient had heart failure that their heart was stiffening? If you knew the heart was stiffening through this pathway or that pathway, you would begin to address it, because then I could teach you how to identify that. You see it on the MCG, you know what disease states cause it to go through the cardiomyopathy pathway, you know which ones cause it to go through the ventricular hypertrophy pathway, and then you start addressing the disease states that cause the problem. Now, it's one thing to know you got a problem, it's another thing to know what to do with it. And so you're going to have to treat these problems from an inflammatory perspective. Mitochondrial dysfunction. We just had a presentation on it. And I got to tell you, mitochondrial dysfunction is huge. And this machine picks it up. It picks it up early, it picks it up late, and all in between. And mitochondrial dysfunction is basically at the basis of why we have diabetes, it's at the basis of why we have cancer, it's at the basis of why we have autoimmune illness. If you could have a device in your office that would just pick up this one thing alone, wouldn't that be fantastic? But now that if you got a device that picks up this one thing plus all these other things, how huge is that? You think about once you turn 50, I've been watching these tests. Kids can have mitochondrial dysfunction, and they're starting to have it more and more because of our nutrition issues. But people over the age of 50 have it in massive number. So if you're sitting here over 50 today and you think you don't have mitochondrial dysfunction, you better think twice, because you very well may and not know it. I teach my medical students, you can't look at a book by its cover. You can look at someone that looks perfectly healthy and they have mitochondrial dysfunction. You look at someone that looks very obese and they are fine. You've got to dig deeper, and this machine allows us to do that. I'm very excited about the future of patients in this area. When we had COVID, and so many of those patients did not do well, they were vulnerable patients, and we looked at it and said, well, it's because they're obese. No, it wasn't just obese, because some obese patients did fine. And we said it's because of this, and no, it wasn't that. I firmly believe this mitochondrial dysfunction was at the root cause of why so many of those patients didn't do well. The other thing was the mast cell activation syndrome that I think the previous speaker was talking about as well. 16% of the American population has mast cell activation. Once they got hold of certain issues like COVID, they didn't do well. All of us here have had people we know that went to sleep one night and just didn't wake up. They didn't wake up because they went into rhythm disturbance with ventricular fibrillation. Wouldn't you like to know who those people are? Others in here have known patients and after patients that had atrial fibrillation. Wouldn't you like to know who they are and try to do something about it before it happens? Can you believe we have a device now that actually sees atrial fibrillation before it occurs? It sees ventricular fibrillation before it occurs. If you saw ventricular fibrillation and you addressed it quickly and then you retested the patient and it started to go away, you would know you don't need a defibrillator. If you treated it aggressively and it didn't go away, that patient needs a defibrillator till proven elsewise. If you see atrial fibrillation coming, there's a study that's not published yet, but it's been completed. And when a person had 5 out of 5 testings positive for atrial fib on this test, within 3 months, 93% of them had atrial fibrillation in occurrence. So this has given us some opportunity to see it, because you're going to do 5 testings of 82 seconds, and it picks up a lot of electrocardiographic data. It goes to this big central computer, it comes back within milliseconds, and then you're going to be able to look the patient in the eye and help them in ways you never could before, including picking up these rhythm disturbance issues. I've done hundreds, if not thousands, of preoperative clearances through the years. Nothing would have made my life any better than this device. My wife got sick a few years ago, so I stopped practicing. I'm teaching in medical school now. But I would have loved to have had this and done preoperative clearances, because I would know which patients had mitochondrial dysfunction going into a 5-hour surgery. Might not advise that. I would know which ones had rhythm disturbances, and I would know which medicines you best not put them to sleep with, and which things we could and could not do. hindsight is always 20/20. I just didn't have access to this, and no doctor does. At this point, when a doctor says they're doing preoperative clearance, and I know we have cardiologists in here that can verify with me, at the end of the day, it's your guess is as good as mine. You give it the best study that you can, you estimate, but then at the end of the day, you don't know who has problems of a severe nature like mitochondrial dysfunction or rhythm disturbance. You do now. If you're a doctor that works in the emergency room, this is going to be the cat's meow. The quicker you get a patient to the cath lab when they come in with acute coronary syndrome, the more muscle you save, the better the outcomes. This test takes 10 minutes to do. You can actually put a person from the time they get to your ER door up into the cath lab once you get this result, because this result's going to tell you yes, no, do they need to go to the cath lab, even without blood work. If you have a long transit time for your ambulance, you can put these devices on your ambulance. You could actually have the report given to the doctor in the ER as soon as you step out the door of the ambulance. How accurate is this machine? Incredibly accurate. The sensitivity and specificity is already over 90%. The negative predictive value is 100% if you set the number at the right level. There was an ER study that was done a couple years ago in Florida, in the 4 biggest hospitals in the state, and they looked at 585 patients and used a cutoff of 4. And if you used a cutoff of 4.0, it had 100% negative predictive value, which means that patient was not in the midst of having a heart attack, did not need to go to the cath lab. There are numerous studies looking at the MCG compared with nuclear stress testing, with SPECT imaging, and it always stands the test of time. It's an incredibly accurate device. If you're a cardiologist in here and you're fretting about the possibility of some of your machines becoming antiquated because of this device, you are probably correct. This will be disruptive. But what I want to encourage you about, forget the disruption and think about what this is fixing to do for your patients. Your patients are fixing to live longer, feel better, do better. You realize if you knew you had mitochondrial dysfunction, you fixed it, how much better you feel? It's unbelievable. It really doesn't matter which way you compare the MCG to other test parameters for cardiovascular disease now. If you're looking at accuracy, sensitivity, specificity, negative predictive value, positive predictive value, this doesn't matter. It actually outperforms everybody in this particular basis. Going up against things like heart catheterization procedure is how you look at these numbers, and it stands up very well in that arena. Interesting thing is it's going to help us to see who needs a heart cath and who doesn't, and it's going to help us avoid some that aren't necessary. If you like to study peer-reviewed information, take a picture of this slide here so you can kind of look to see where the peer-reviewed studies are right now. That's about 12 of them. All right. Where is this device going to be used? It's absolutely going to be used at wellness clinics, in primary care clinics, in OB-GYN clinics, in any type of clinic that deals with patients that want to stay well and live longer. Does this fit in an anti-aging conference? My goodness, yes. Do you realize the life expectancy that would go up if you took care of cardiovascular issues before they became a problem and you fixed mitochondrial dysfunction? You know, if a person has mitochondrial dysfunction, that triggers that cell to go from oxidative phosphorylation to fermentation. It mutates and works its way to that fermentation process. Most of them don't make it, but eventually some cells do, and now you have a tumor. Do you realize if we fixed all of that, how much longer people would live? If you downregulated cardiovascular disease and you downregulated cancer, could you be 100 and 120 and still play golf? And the answer is, I think so, if you stayed active. Once your mitochondria are working, you have energy. Everything is functioning. Your muscles, everything is working the way it's supposed to. You can do better. Is this going to get used in the ER? Absolutely. I'll be shocked if in 5 years every ER in the nation doesn't have more than one of these devices in their ER because it's that important. Many gynecologists do a large portion of women's health, especially the primary care arena. And now that we know that, wouldn't it be nice if we got these devices in women's health and gynecology offices so they could pick up this disease earlier? If they're the ones that are going to see them on a yearly basis, just get their patients a score every year and find out exactly what their cardiovascular status is. Pick up the small vessel disease, pick up the mitochondrial dysfunction. Now, it's one thing to know you have plaque developing in the left side of your heart, the right side of your heart stiffening, mitochondria. It's another thing to know what to do with it. So today's conversation is opening the door to more conversation. I'm probably going to need to come back and talk about what you do with some of these things, but I'm going to briefly mention it today so you can kind of get an idea. In my introduction, he was talking about the 10 disease states that I deal with that helps reverse coronary disease and coronary plaque, and really plaque anywhere. Your plaque in the brain and your plaque around the heart work differently, so you do have to approach them a little differently, but they're both very reversible. You basically have to look at these 10 disease states and realize they're the origin of most of the inflammation that gets in the bloodstream. There's over 1,500 known inflammatory factors that come from these 10 disease states. Does the patient have diabetes? Yes, no. Does the patient have hypertension, dyslipidemia? Yes, no. And then you treat them from an inflammatory perspective. Do they have obesity? And where is that obesity? Is it sub-Q? Is it visceral? Is it liver? Do you not realize that 25% of kids under the age of 18 now have fatty liver? When I was a medical student graduating school, 0% of kids had fatty livers between the age of 0 and 18. So what has happened? Well, that's a story for another day too, but we've had some nutritional changes, and I can probably contribute a lot of that to high fructose corn syrup. We have to watch glucose at larger levels, we eat more sweets. Do you all realize they're putting glucose in Inflamil and other formulas? So our babies are getting addicted and conditioned to sweetened foods before they even stop using formula. Sleep disturbances. If 8% of people have sleep disturbances from the mechanics, the factory side, that's sleep apnea, shift work sleep disorder, or narcolepsy, and then you have probably another 40% of people having sleep disturbances from substrate problems. There are substrate issues that are terrible in sleep products. For instance, there's a condition, all aware of, because this is a group that's anti-aging, the MTHFR genetic mutation. That mutation is in 50% of the American population, either in the 677 or the 1298 area. Now, if you have trouble with these mutations, you're going to have difficulty making serotonin, melatonin, dopamine, norepinephrine, which is the definition of a sleep disturbance, which leads to a sleep disorder. 50% of the people in this room have it, 50% of our patients have it. We're just not addressing it at that level right now, but we need to. Chronic kidney disease, partly because of the way we treat certain things like swelling. We throw them on a diuretic before we ever consider an aldosterone blockade, and then before you know it, we need to raise the dose of the diuretic, and we raise it 2 or 3 times a month. Shortly after that, we've got patients with chronic kidney disease. The amount of patients that have insulin resistance that goes unaddressed leaves us with patients getting chronic kidney disease. Patients that have hypertension that basically don't take the medicine or avoid the condition. Get it to mental health disorders. Some of those mental health disorders are in the genetics like the MTHFR, because if you don't realize there's a combination between genetics, sleep, and substrates, we're not having the same right conversation. See, if I ask you to make me a cake, and I take away your flour, you can't make a cake, because I just took away one of the main ingredients. If I ask you to make serotonin, melatonin, dopamine, norepinephrine, and I take away your methylfolate, not going to happen. If I diminish your omega-3, or your vitamin D, the serotonin's going to be influenced too. So we've got issues there to take care of that affect this problem. You say, well, why would sleep have anything to do with cardiovascular disease? Well, people that don't have serotonin and serotonergic nerve compensate by circulating high levels of adrenaline. And high levels of adrenaline cause you to be inflammatory. That's putting plaque in your arteries and setting the stage for vulnerable plaque that will rupture one day and cause trouble. There are various autoimmune illnesses that cause this problem with cardiovascular inflammation. You've got to turn it off. Yes, no, do they have it? Sometimes that starts at the mitochondrial dysfunction. We just got to get better at noticing it. And this is a group that treats the last one, gut bowel genome issues. Gut bowel genome issues are big. I can't talk much longer about this because I want you to see the report and see how it works. This is a patient, MCG. I blocked out the names and the ways of identification of this patient so you can see the data. It's a 73-year-old female, and each one of those lines, each one of these lines right here are 82 seconds of testing. So the patient's laying on the table, they got metal in their pockets, they're taking their belts off. They're in a room that doesn't have electrical interference, and then they get these recordings. You look then at the quality of the tracings. Is the quality good, bad, instead marginal? If they're marginal, you have to go down and look at a different part to see why it's called marginal. If it's acceptable, you accept it, and this patient was. You got a next category there, has to do with local and global. Local means single vessel disease versus global being multi-vessel disease. This particular patient says present 5 times under local, which means this patient has local or single vessel disease issues. You see the ischemia score now on the right-hand side of this picture. The score goes between 0 and 22, but if you see anything over 4 is considered significant. This patient's, all of the numbers are over 4. We then go to a special disease state category and categorize these patients. This patient has 2 going into category E, 3 going into category F, so this patient has intermediate to high level disease. Now here's the meat and potatoes of the MCG. The page you see on the left is the second page of the report. This on the right-hand side is the third page of the report. I chose to put them together so you could see them simultaneously, so I'll discuss them, make it easier to have the discussion. We always look first at myocardial damage. And myocardial damage answers the question, does my patient have one of those 10 disease states that create inflammation, yes or no? And if they have active disease, it would be positive. And in this case, the positivity was 5 out of 5 under myocardial damage. The second thing we look at is the disease state metabolically, is it acute or is it chronic? Is this something that's brewing viciously right now in this patient, or is it something that's been brewing like coffee that sat on a coffee pot for a while? The acute stage has to do with myocarditis, which is right about right there. Went down. Trying to remember what this patient had. 0, I think. 0 out of 5. And then we're looking at the chronic disease state right over here on the left side of page 3. It's under myocardial remodeling. Patient was 5 out of 5. So what we know now about this patient? This patient has a metabolic disease state that's chronic in nature. It's been there over 2 years. If you've got 5 out of 5 positive, that's going to be at least a 2-year issue. And now we want to know a little bit more about this patient. Is this patient's disease large vessel disease or small vessel disease? It turns out it's large vessel disease. Sorry, I'm going back and forth, but I'm trying to be equal. You see under increased myocardial remodeling here, it basically shows 5 out of 5 positive. That means the disease state is greater than 30%. If it says decreased myocardial remodeling, not remodeling, but compliance. If it says decreased myocardial compliance, it's under 30% included. If it says increased myocardial compliance, it's over 30%. In this case, we're over 30% included in some vessel. Now, which vessel is included? We ask. The next thing we see is we go to right over here where it says rheumatic heart disease. And I think we've got 2 out of 5. Then we have pulmonary heart disease, and that's 1 out of 5. Rheumatic heart disease represents the left-sided vessels, the left coronary vessels. The right-sided vessels are represented by pulmonary heart disease, which is right coronary artery or the circumflex. Then we want to know, does this patient have any congenital heart defects? And interesting enough, 5 out of 5 positive. Now, this patient, just because they have a congenital heart defect doesn't mean it's a substantial one. It may not be one contributing much trouble. It might be a mild valvular abnormality, maybe a very small atrial septal defect. But regardless, it's picking up something that's not supposed to be there. It's worth to check it out. Now we want to know, is the patient's heart stiffening or is the patient's heart not stiffening? We start looking right over here at cardiomyopathy, which is 5 out of 5 positive. Ventricular hypertrophy, which is 5 out of 5 negative. This patient does not have heart stiffening. We now want to know if the patient has mitochondrial dysfunction, which this patient has rather significantly. If you look right under the decreased ejection fraction, acute power failure, it's like the third one and the seventh one, I think. The acute power failure and the increased ejection fraction. So on page 3, see if it's not the fourth and the seventh. Fourth and the seventh. That's what it is. Those represent mitochondrial dysfunction. And lastly, we want to know if this patient has any rhythm disturbance potential. And actually, this one has a serious rhythm disturbance potential. If you look right over here, you see 5 out of 5 positive under ventricular fibrillation. This is a patient, if we don't address these issues quickly, he's fixing to go to sleep one night and not wake up. Now, this is just one patient. This particular patient was a patient that I saw in an aerospace meeting just last year. And the husband was very large, she was rather thin. I expected him to look really messed up on his MCG. I expected her to look pretty decent. It turned out to be the exact opposite. He was obese and modestly okay, metabolically. His wife, who was 115 pounds and about 5'5", she had a good BMI and she looked okay superficially. She was completely messed up. I was scared to watch her walk out the building. So what do we do for this person? We one by one address the 10 disease states. Yes, no. Treat each disease state from an inflammatory perspective, and that's a conversation for another day. And then one by one, you're going to see those pluses go to minuses. You realize that I used to get a lot of 95% blocked arteries. In fact, on any given day, I took care of at least 12 to 15 of these patients every day. The medical students used to just be mind-boggled how many of these people were out there. These were inoperable, unstable patients. They were sent to from all over the country, but invariably, if they had that MTHFR genetic mutation and I was able to get the right dose of methylfolate into them relatively quickly, within 2 weeks, they would start making nitric oxide. Their arteries would go from 95% blocked to 50% blocked almost instantly within 2 weeks. And so you can get a lot of people out of trouble real quick if you just kind of know some of these things about the disease state and treat it aggressively. Patient 2. If I start running out of time, just wave at me. I got 10 minutes? All right. I got 2 more patients. We should have no trouble doing that in 10 minutes. You already know this is 5 testings for 82 seconds. This patient has single vessel disease, but if you look at those numbers on the right, they're pretty high. When we score them, the scores in the category F department for 4 of them, scores in the category E department for 1 of them. That means this patient has intermediate to high levels of myocardial dysfunction. That's not good. When we start looking at this report, we always start at the myocardial damage, which is on the left side of this page, about the middle of the page. 5 out of 5 positive under myocardial damage, which means this patient's metabolic disease active. Is it acute or chronic? This patient has 2 under myocarditis and has 5 out of 5 positive under myocardial remodeling. That means this patient has both acute and chronic disease states. The chronic disease states is probably having a higher impact on these patients. coronary disease. This is patient's disease, large vessel or small vessel. It's definitely a large vessel. If you look at the increased myocardial compliance right here, it's 5 out of 5. Remember, increased myocardial compliance means this disease state has plaque above 30%. When you say above 30%, that could be 40%, it could be 80%. You have to kind of look at the whole patient and figure it out, but at least you know the patient has a high level of plaque. You realize the most common heart attack is not an 80% plaque, it's a 40% plaque. If it was stable enough to get to 80 or 90%, it's fairly stable plaque, more than likely, but if it's unstable, by the time it's 30 to 50%, it's getting ready to rupture. So I used to marvel when we get CTAs back and they would say mild to moderate coronary disease in a certain area, and then you realize 2 weeks later these patients have heart attacks because the plaque is unstable. Fortunately, even in the CTA arena now, we have software to help you see soft plaque, just like the ECG will do. Which side of the heart is this disease on? It's mostly single vessel. You can see pulmonary heart disease showing up pretty high right here, 5 out of 5. The rheumatic heart disease is basically 0 out of 5, which is the left side disease. If you look under global asynchrony, you can see the caret is pointing toward the 2. If the patient has global asynchrony, you look at the caret. If it's pointing toward 2, it's right-sided disease. If it's pointing toward B5, it's left-sided disease. Remember, this particular EKG only has 2 leads. So it confirmed what we already saw with the other. It's right-sided disease because the caret's coming toward the 2. Oops. So I take that back. I didn't mean to do that. Does this patient have a congenital defect? The answer is no. Nothing showing up under congenital. Is there heart stiffening going on? And the answer is yes. If you look the far left side here, cardiomyopathy, you're seeing 3 out of 5 showing up positive. You look on the right side of the page, 2, 0 out of 5. So there is heart stiffening going through the cardiomyopathy pathway, but not the ventricular hypertrophy pathway. You realize in the cardiomyopathy pathway, things like alcohol, toxins, diabetes play high factors. The number one risk for cardiomyopathy developing and acquires it is alcohol in excess. Diabetes is pretty darn close to it. Congenital defects because of the MTHFR can take, and some of these people have all of the above. And so we have to address all those issues. The ventricular hypertrophy route, if you see that, it's almost always going to have an insulin-resistant component. So that gives you some ideas of which areas to address when you see which way the heart is stiffening. And then you just go about between disease states and treating the way we discussed. This patient is a patient with small vessel disease. That's why I threw it up here so you can see one that did have small vessel disease. You see the scores between 2.5 and 3 or 4. So we have mild to moderate disease in this patient, but most of them mild. Where you see the small vessel disease, if you notice here on the second page under increase and decreased myocardial compliance, there's nothing showing up. When your score is above 2, but you have nothing showing up in either increased or decreased myocardial compliance by default, that is small vessel disease. And so then you can get to work on this patient's small vessel disease at an early stage. And tell them how much good we can do for the 49% of women and 15% of men in that category when we see this. If you noticed, a lot of these have mitochondrial dysfunction. This one's got 6 out of 10. Mitochondrial dysfunction is way more common than I ever realized, and maybe more than you realize. When you start doing this testing in your office, and I can't imagine any of you not, it's just a matter whether you start doing it now or you start doing it in 5 years, because this is coming, it's progress. You're going to be shocked at how many patients that look pretty decent, they look pretty healthy, and they got mitochondrial dysfunction, and now you can do something about it. I basically want you to blend the old with the new. We're not going to stop doing all these other things. We're just going to be doing them a little differently and doing them less. You'll still be looking at history physical, you'll still be grabbing on advanced laboratories, you'll still be addressing things like you did before. But if you add the MCG to what you're doing now, the likelihood of you having better outcomes is almost certain, especially once we teach you how to read them and then we teach you what to do with the information. We're going to get more bang for our buck. This test is not terribly expensive. EKGs are not terribly expensive. MCGs are not terribly expensive, so we're going to get something that's cost effective. The cost of an MCG is generally cheaper than the copay of a nuclear stress test. If you can just imagine it, in the United States, there's one person every 40 minutes that has a heart attack. In the length of time I've been talking to you, someone's had a heart attack. And if we did another conversation like this, another one and another one, we're talking about every 40 seconds. I'm just going to say every 40 minutes. Every 60 seconds, a person has a heart disease-related death. Every 40 seconds, someone has a heart attack. So we actually have about 40 heart attacks right now. I challenge you to be a difference maker. I think of groups like this that are working for anti-aging, it's like Fillingane people. You guys are heroes to me because you look deeper, you personalize medicine, you give a dang, you have your own clinics many times at your own expense because you realize you can't do it and work for a hospital because they'll tell you what to do and what not to do. So I applaud you for the ones that are doing that. Think about what we can do with this device in that scenario. I left a few minutes for questions. Right? I think I did. Are there any questions that I have missed? Yes?
Where would you find the devices for this?
There would happen to be one of the vendors today out there that has a machine that would help you with that. This device is the biggest breakthrough I've ever seen. I would be running to get one of these if I was in your shoes. I love technology, but this is the most exciting technology I've ever had. I used to buy junk. I used to buy R2R interval stuff. I would find anything that came out that I thought would help my patient a little. But this right here, this is going to go way beyond helping a little. It's almost mind-boggling how much information it gives us. Where do you do calcium scanning or scoring now? This does the same thing, but it just gives you so much more information. It tells you about the plaque, it tells you if it's soft, and then it gives you a score, and then it gives you the heart stiffening, and then it gives you the rhythm disturbance information, the mitochondrial dysfunction. You see this? There's just nothing that compares. Well, if there's no more questions, I'll let you go to the next topic. Thank you for having me.